which is trained using data, and that data is very important, and algorithms are very important, and equally important or even more important is compute. You need very heavy compute for these things because data is large. So Mycin is one of the Mycin was one of the another AI system in 1970s built in Stanford for diagnosing, you know, diagnosing and treating bacterial infections. They went and talked to hundreds of doctors and found out how they treat based on what parameters, what recommendations they give, etc. And they tried to codify that in terms of a program. A computer program is nothing but if this happens, that happens, etc. So they thought you could just capture the knowledge of the doctors and create a program that behaves like that, which was a good attempt. But the knowledge of the doctor contains so many things beyond what is explicitly you can say, you can document. So it probably didn't go too far in that. Yet there are many successes in the recent times, especially in one of the signature applications is radiology, image analysis, and computer vision has been areas that people like me have been working on for many years. I mean, I came later, but maybe for 50, 60 years, people have been working on image analysis and treating X-ray images or MRI images and analyzing and looking for what doctors look for in them, the defects or measurements, etc. That is very much possible, and that's very much a computer or AI task. And one of the big prospects is, of course, personalized medicine. If you know if you know everything about a patient, the medicine that you prescribe or the treatment you prescribe could be very specific to that patient, given the patient's genes, maybe the past conditions, the recent dietary habits, and so on. All that can be taken into account because computer programs can process megabytes or terabytes of data very quickly, more than human. So that's a huge potential there. In drug discovery, this has been applied, instead of just looking at the traditional way. And this year, the Nobel Prize was given to AlphaFold, which studies protein folding, which is a step 1 or step 0 towards drug discovery. And that is a very AI-driven tool. Robotics and assistive technologies, of course, we are always familiar with that. And there are many. Yet, you look at radiotherapy. What are the accidents in radiotherapy? I just did a very quick search. There are long history of accidents in radiotherapy, things going wrong and patients dying, patients being subjected to very high doses of radiation, etc. And there's a whole report on it. Most of them, one of the major reasons is dependence on the machines. And the machine says something, presumably there's a doctor or an operator or somebody who's in charge of the patient, but they trust the machine too much, and even when the machine make mistake, they're not checking, they're not vigilant enough. This is one of the major reasons. And a very easy to understand example is, there were these Boeing 737 Max. It ended up 2 of them crashed, one in Ethiopia, one in Indonesia, and both of them, it was later verified that it had a faulty sensor. The sensor told the plane that it is stalling when it was not actually stalling, and it took corrective action, which made the plane go down. And the active pilots there, they knew it was not stalling. They tried to pull it back. It'll pull back for some time, but again, the information from that sensor will take over. They could not control it. Somehow, pilots had no option to go fully manual. And that's the documented reason for those crashes. I mean, it's just that automation carried too far. And one of the other examples I like to say is about Down syndrome markers. And this is told by Professor Michael Jordan, is one of the foremost authorities in machine learning at University of California at Berkeley. He talks about his own experience. His wife got a routine ultrasound when she was pregnant in 2004, and found some white spots in the image, which were told as which was markers for potential Down syndrome with the risk of 1 in 20. And to confirm, you have to do the amnio, which has a risk to the fetus of 1 in 300. And so this man, being a very analytical man and a machine learning person, he went around, looked at how this diagnosis was made, when this machine based diagnosis was made, and if so, he realized that in a UK study in the 90s had recommended this procedure, and he also found out that the machine used, the scanner used in when the studies is very different from the scanner used today. The scanner is far more advanced today not today, 2004, with more uh, with more resolution. So he concluded that the white patches are really the signal noise. If you take your camera and shoot something in very dark regions, you see white patches there. That's called noise, signal noise, and that signal noise is the reason for that white patches, not the real one. He went and told that to the he went and told that to the geneticist and she said apparently, oh, that explains why we started seeing an uptick in Down syndrome diagnosis a few years ago. That's when the new machine arrived. Okay, the machine had been changed, had come, but the algorithm was assuming the old machine. And Michael Jordan calculates thousands of ultrasounds would have been held on the same very day across the world, and a good number of them would have come up with this diagnosis, and some of them would have taken that amnio, and a few babies would have died unnecessarily. So this is a somehow mindless application. The signal changed, but the algorithm did not change. So these are the things that one has to be worried about. There's so many good things in with AI can do. And very recently, just a few weeks ago, Elon Musk tweeted that he has a AI engine called Grok, that part of Twitter or X, and he said, just try submitting your radio images, and your Grok will do the diagnosis. And people submitted all kinds of things, and of course, you read the feed, there are all kinds of good examples of it diagnosing well, but a lot of bad ones also, or very weird ones also. But I mean, the question is whether it is accurate or not. To me, the question is, is it right to ask some people to publicly upload our, something that as private or as personal as your scanned images? Is it right for someone to upload if somebody asks? And who is giving the advice? Who is taking it? How is the advice given? Who is responsible? There are many such questions. Such a public forum, you submit your thing and that it says something and now you don't know what to do. Okay. So what about the whole privacy and other issues? So these are things that come up. So at the root, a machine learning system is just think of it as this is not mathematics, a function that goes from some input to an output, and the y on the output is maybe a diagnosis, maybe some probability of something, maybe a severity of a disease, etc. And the input f is a set of scans or vitals and all the other parameters. But the important thing is this machine learning happens on this data. And system can only be as good as the data provided. Errors in the data will affect future decisions. Biased data, the data comes from only certain kind of very severe cases, then it will not know what to do with the not so severe cases or the mild cases. It'll also treat them as severe potentially, and maybe unfair in the sense maybe this data represents more of population of certain kind, and the characteristics of another kind of population is not addressed there. And these are the very questions that Michael Jordan also said. The algorithm, the sensor changed, but the algorithm did not. The data changed, data input changed, but somehow that was not accounted for. So here is this is what happens today. Of course, things like ChatGPT, Llama, Gemini, these have become, we all know about it, one of the most widest popular things in the world in terms of uptake, from start to million users. It happened a few hours, okay? And it feels like a know-all oracle that has actually read every book available on every book available digitally, practically has been read or munched by this chat GPT or that kind of system while training. It's very expensive to train. The estimate takes $200 million to train one. But it works wonderfully for most part. We have tested all of them. Writes very nice text. and does very good things often, but it can hallucinate. Okay, it just makes something totally weird thing, and that just cannot be. I mean, it's okay when AI system makes an error when you are recommending movies or recommending a music, but it's obviously not okay for medical diagnosis or many other fields, not just medical diagnosis. So the point is, these are all very good, but with lot of hazards. So to me, the takeaway is modern AI can connect and analyze vast and diverse data that humans cannot. Just like cars can drive much faster, planes can fly much faster than human beings can. And these are tools. This can provide useful and rare insights to the practitioner. But it should be treated as a very, very sophisticated calculator. It has to be a tool in your hands, in the practitioner's hands, not practitioner is a tool in the AI's hands, right? Algorithmic methods have their limitations, as we saw. AI will obviously play a large role in medical sciences, but professionals should know enough to exploit AI appropriately. In the morning session, it was made, suggested that an AI course should be made compulsory for all undergraduate medical education. I fully support that because today's students or professionals will be coming in using a lot of AI tools, coming in contact with people who are trying to sell them AI tools. So they should be at least aware a little bit. So there is a lot of hype which needs to be recognized as hype, but there's a lot of stuff also which should be utilized properly. So I'll end with this cartoonish thing. In 2015, Elon Musk said self-driving cars will be here in 2 years. And 2016, the person there is Jeff Hinton, who was given the Nobel Prize recently for this AI discovery. He said really radiologies will be obsolete in 5 years. I mean, he saw the progress of AI in interpreting images. Said radiologists will be obsolete in 5 years. So this internet meme said, of course, in 2024, here are all these radiologists traveling to work in their regular cars, non-electric, non-self-driving cars. So this is the point. There's a lot of potential, but if you take it the right spirit. I'll end here. Thank you all for the opportunity.
Thank you. Thank you, Dr. Jainaran. One thing that is one point from my comments, there was an editorial in Annals of Surgical Oncology after this AI and there's a very senior surgeons, the hyposcilia. Means people are using like machine learning, making the people hyposcilia. That's how it reflects your emotional attachment with the patients and they can taking over by the machine learning. Any comments from your side?
No, nothing specific. Yes, I mean, see, all these tools today, we have all become addicts of tools, right? So AI tools, when simple phone that we are all addicts to. Similarly, all these tools, you have to know how to use them, when to use them, and when not to use them. I don't have any special insight on that.
Anyone from audience, if one or two comments or questions?
Sir, I have a question.
Yeah.
As far as raw data is concerned, for example, the range, blood sugar, lipids, etc., or the images and their size and etc., that you can feed large number of data and then artificial intelligence can answer that. But with regard, I'm a mental health professional, I'm a professor of psychiatry. We can give certain scales like so and so emotion is present or absent. That artificial intelligence can say. But when it comes to interpretation of the facial expression, for example, how the person reacts, how is his emotion, his expression of his eyes, non-verbal communication, these parameters, how AI is going to handle and how we are going to store the data.
I think there is a lot of work on similar things. So if you watch somebody intently with multiple cameras while the session is going on, analyzing what they're doing, another micro expressions, etc., that the machine can do. I mean, machine can do, but an expert has to guide the machine what to look for. Okay. machine is today with the very high resolution images and very powerful computers. Practically anything that you want to analyze can be done, provided you can tell the machine or tell the designer of the program what kind of things are you looking for. That has to come from the domain. That has to come from expertise of the people like you. Machine cannot learn it by itself. So that's the whole point. Is if in the hands of good experts, this can be a very powerful tools. But believing that it shows something well, which means it can also do everything else well. That if you believe that, you may be in for a surprise and rude surprise. And that's what is happening in Chat GPT, for instance, does ordinary text so well, and you think it's a very intelligent machine. Okay, but it just doesn't have any intelligence behind it. It's just repeating things. Similarly, any so facial analysis of somebody's behavior at a very close, nice, fine scale is being done in computer vision. Mostly research today, but it can be connected with a diagnostic practice if there is enough. That needs partnership between people who do computer vision and people who know the medical practitioners who know how to interpret it, what else to look for. It will be an interactive process. It won't be like one time.
Okay, thank you, Professor Narayan. We will go for the panel discussion. We will discuss all these things. Next one, Dr. Nina Khanna. So it's from Amrita Institute of Medical Science. After this presentation, we will have the panel discussion. That time we will discussion from the questions or comments from the audience. Thank you, sir.
Thank you, Namscon and AIMS Jodhpur. I have a very long connection with AIMS Jodhpur. I have a lot of my students working here. After retirement, people told me you need to stimulate your mind. So I got into artificial intelligence from the clinical side. Professor Narayanan is the other side of the spectrum. I'm the clinical side of the spectrum. And I'm going to talk from the dermatologist perspective because dermatology is an extremely visual field. So you can't fool the patient, you can't fool the camera, you can't fool the disease. So there are so many derma AI-based, AI-enhanced apps, but when I say recent, it is March 2024, and I'm sure a lot of people must be thinking it's obsolete as far as AI is concerned because AI, what is present in the morning becomes obsolete by evening. So they've evaluated 909 apps. There were 391 which were, the rest were excluded and 391 remain, and 350 were actually then excluded because of non-medical nature of the app. So there is a lot of hype going on, unvalidated apps available, and eventually 41 apps were analyzed, but none of these apps were FDA approved. Fortunately, there is recently a derma sensor, which is a AI-powered non-invasive device to diagnose skin cancer, which has been approved by FDA. The other apps, what they found that they lacked supporting evidence. There was sparse input from the clinicians. There was lack of transparency in the algorithm development, and that's what Professor Narayanan was talking about. How have you developed the algorithm? And there were issues with user privacy. Now, as I said, after retirement, I sort of got into a bit of AI thanks to the Amrita Vishwa Vidyapitham, where you have a BTech in artificial intelligence data science and medical engineering. So now the first thing we looked at was generic, something which can be extrapolated to other specialties. So not necessarily dermatologist. And the genesis was that history taking becomes very time consuming, not because we are taking a detailed history, but sometimes when you ask a patient a very simple question, कि कब से ये problem है, The wife turns around and tells the husband, "जब तुम्हारी माँ से लड़ाई हुई थी." So the husband responds, "ये कौन सी वाली लड़ाई की बात कर रही हो? आपकी तो रोज ही होती है." So, a simple question doesn't give you a correct answer. Or if you ask them what are the previous prescription, they'll give you, I have taken violet 2 tablets, indigo 2 tablets. So it's the Vibgyor which comes around. Or koi malam laga diya. This is a dermatologist. I'm a dermatologist, so that's how they respond. और इफ यू आस्क देम फॉर लैब टेस्ट दे से, अच्छा डॉक्टर साहब 1 मिनट रुकिए, मैं फोन करके अपने हस्बैंड से पूछती हूँ, मेरे लैब रिपोर्ट्स फोटो भेजेगा. So what we decided that, that our consultations were taking about 20 to 25 minutes, of which about 15 minutes were actually being used not for questioning or examining or counseling the patient, but almost, I would say, waste of time. So we decided that we'll enhance our consultations with an AI chatbot. So in this background of what I just said, we thought we'll streamline patient intake process using a digital pre-consultation questionnaire and improve the overall efficacy and quality of care. So what we did when the patient arrived, we asked them to scan this QR code and fill up this questionnaire on their smartphones, which would gather patient history to sensitize them on the likely questions they would be asked when they come for the consult. We've actually validated. I won't use the word validated because it'd be unscientific. We've tested this on hair fall and hair sparseness, which is an extremely common complaint in our patients. And then they fill in the questionnaire and they submit the information to a Google sheet, and then they come for consultation to us. So this is what it looks like. This is actually this is the breadth and the depth of the questionnaire. So it's a very extensive questionnaire. And so when they come to us, they rapidly answer our questions. And when we asked the patients their feedback, they were quite comfortable providing the information, and they found the information useful. The questions were relevant. And what was very, very important was that it reduced our consultation time by almost 7 minutes. So from 12 minutes, from 18 minutes, we came down to about 12 minutes, which I thought was very cost-effective utilization of time. So we plan now to go refine this further and cover other dermatological complaints and integrate into our HIS. Amrita is completely on the HIS, and we would like to refine this chatbot interface and functionality. So we've sent up a proposal titled Enhancing Dermatology Consultation Through a Targeting Branching History. So you'll ask them, what is your problem? So their pigmentation, hair fall, and then they'll vertically go down that particular branch. Now, dermatology specific questionnaire. Now, I think when I joined dermatology, they said, oh, kya karna? Tumhare ko khali steroid hi dene hai. So, but must remember that there are some dermatoses which respond to steroids and some which get aggravated. Something like psoriasis would respond to topical steroid. Sometimes something like tinea or ringworm would get aggravated by steroids. So we are now developing an app, training an app to triage itchy skin diseases into steroid responsive and steroid aggravated dermatosis to optimize treatment in the community, because the patient goes and tells the primary health care physician that I have an itchy problem. The doctor just prescribes a betnovate or topical steroid and says, ye le lo, and the patient really improves. But the minute you stop the steroid, the problem gets aggravated. Now, the rampant misuse of topical steroid has actually led to a very made in India epidemic of superficial fungal infection. This is truly what Modi ji says, make in India. This has been exported globally and has even penetrated China. So something as banal as this becomes incognito like this, so it cannot be recognized. So it's nothing like a ringworm, but this is dermatophytosis, or becomes so deep and extensive and resistant to treatment. So the second AI-based app which we are looking at is to classify itchy skin diseases into dermatophytosis and non-dermatophytic itchy dermatosis to reduce the irrational misuse of topical corticosteroids in tinea infection. And to improve treatment outcome, this is a very small grant we have received, but it's a very prestigious grant to evaluate the effectiveness of an AI-enhanced mobile application in improving management outcomes of atopic dermatitis and RCT. The small grant, but it's come from our national body. Now, what we will do in this app is to send reminders for medication. So the patient will actually take a photograph, get it converted into text, get it converted into reminders, and later we will try to upscale it and indicate to the patient when the patient takes the pictures to upscale the medication from moisturizers to safe dermatological medications or see a dermatologist. So something like this, which can be managed with a moisturizer, if the patient becomes like this, we will say, now go see your dermatologist. Now, it's important to remember the scope of AI in healthcare is huger than huge, but with the caveats which Professor Narayanan indicated. Now, I Googled this morning. So if you look at the articles in visual fields like dermatology, radiology, pathology, upwards of 25,000 in just 2024. So also in interventional fields like surgery. Now, ICMR is now making an Indian data sets, gold standard data sets, and we are now part of that program. And some, like dermatologists, each of us would have over a period of time collected more than 10,000, 15,000, 20,000 images. We're likely to share them with ICMR so that we have data sets from India. Thank you so much.
Thank you, Dr. Khanna. Now, we have a panel on role of AI in healthcare. Can I invite all the speakers to come on the podium here? Dr. Khanna, Dr. Narayanan, Dr. Vinod, and Dr. Amit Gandhi, please. Dr. Khanna, please join us on the podium. Please. Narayan, to the this is a panel for discussion. I would request of you to be moderator for the article. Two of the presentation we already heard. But what about Dr. Gandhi and Dr. Vinod? Do you have any presentation to make or you want to participate on the direct? Okay. So the moderator for the. Can I start with the first question? Dr. Narayan, can I start with the first? No, I'm and AI has really made tremendous difference in the clinical practice. Last, I would say 10 years. So from the postgraduate, what are the difficulties you face which AI has, in your opinion?
I think, as I mentioned in my presentation also, now malignancies was something which is not, skin malignancy is not very, very common in India. But if you look at the West or you look at Australia, rampant there, if I look at an international conference, 1/4 of the any international conference is dedicated to management of, I think you would also vouch for that, as a plastic surgeon, is actually dedicated to treatment of or diagnosis and treatment of malignancy. And the only FDA approved app is also on diagnosis of skin malignancies. So I think the gravity is there that skin malignancies, the sensitivity and the specificity of the app is reasonable, and that is why it's been approved by FDA. So that is one aspect. Now, going beyond what I discussed, think Dermatopathology, again, pathology is a visual field. So there also they are developing apps where, they're feeding in images, and the diagnostic sensitivity and specificity is around 85-90%. I think with greater training and larger inputs, I think the diagnostic specificity and sensitivity would increase very much. One other point I would like to make, I think most of these apps are based on images from white skin. And that is why the ICMR has the hub now where we are all hooked onto, and we're going to be giving them data. I think it is a meeting in Bangalore in December, where we are, I'm not going for the meeting, but one of my co-investigators is going for the meeting. And we're going to give them our data sets so that, we can have a collection of our own images.
I wanted to, because most of the data what we are getting is from the overseas. This is the need of the time to actually prepare a data from Indian clinical practice and share this data on a platform so we can be more truthful or close to the clinical practice.
Madam, one point. Says, when we are discussing all these things, there is one ethical and legal issue. When data we are replicating from the US, so Western data, it is not that app modules not this. Because of human body, there's some variations are there. Each individual, some variation is there. How will you address? Because we have not streamlined our ethical legal issue. How it will be
App grant which we've got from our national body when we went to our I'm part of that ethics committee also, but I abstained from participating in that. We've not got ethical clearance for that because of data privacy and data safety. So we've now asked our AI department, because Amrita has a large AI, we have a college of artificial intelligence also. So we've asked them, so we're going to work around it. The recent guidelines, I think the government has made, which are extremely tight on privacy issues, So I think Dr. Narayanan would be able to help us work around that also, because we would definitely need indigenous data sets. I think because we cannot work just on, see, even psychiatry, dermatology, of course, because skin of color is completely different. What looks blue in white skin looks black in Indian skin.
Okay, so yeah, good point. Actually, at IIIT Hyderabad, we have what we call a data foundation, which is a technological basis for our data. I mean, data that anybody wants. This is open to academics, researchers, etc. If they want to store data and get some services from the data, use the data. I mean, only the base. Data has to be collected by somebody else. We are doing some of our data collection also, but that's the more important thing. I mean, storage is slightly easier than collection. So I would, these two members here, Vinod is a faculty member at IIIT Hyderabad. He's been working with developing some of the solutions, the AI-based solutions. I'll request him to explain some of those parts first, and then Amit also is from MedTech, he's from industry background. I'll ask him to say a few words at the start, then we can do the discussion.
Thank you, Professor P. Narayanan. So in terms of the data, that's one of the major bottleneck when it comes to developing technology which is specific to India, right? So some of these technologies like FDA approved technologies that we are using right now has been tested on the population where, where there could be a lot of differences in when it comes to the genetic diversity of Indian population. So that's one of the bottleneck that we are trying to resolve. So I work in the area of digital pathology, where we are trying to digitalize the whole slide biopsy slide images and trying to create a repository that will serve as benchmark data sets for anybody who are interested in developing any of these AI technologies using those data sets. And we also think from the aspects of accessibility and affordability, that part that we discussed in the morning. So we are also looking into developing screening solutions, specifically in oncology space, where we are trying to do a oral cancer screening app, which helps in community level screening by taking the photographic images of the oral cavity. So this has been now getting validated at multiple locations right now. And in terms of the affordability part, no, we are trying to connect the imaging to the genetic level changes. So we are trying to see the relationship between the morphology and the genome-wide changes. So we are trying to see if computer vision can predict the molecular changes using the morphological features of the images. So thereby you avoid the extra genetic testing which many of the patients undergo. So these are the areas where we are trying to see if we can bring the democratization part of healthcare, where we believe that our dual mode of healthcare delivery has created these differences in terms of accessibility and affordability. So we are trying to see how the technology could be a leveler here. So that's the
Here one doubt, like you is already there is a lot of negative things about AI in USA. When you are telling that this imaging, any image we are taking, any specification we are keeping this type of camera, you use that image will be into the data. Because each things that can be the change. Yeah. Like in PET CT, if you initially started, like that is the each molecular imaging cannot be the image. This is less than 2 millimeter that cannot be interpreted as you.
Yeah.
The same thing like any image, you are taking photography. So what is the specification camera? All these things varies also because some data, and that way you will clear different AI images and how will interpreting these technical issues. Give some idea that.
Yeah, so that's an interesting point because when it comes to capturing images, right? So, for example, the example of oral cancer, you can use the camera which is available in any phone these days, and it comes with different resolutions. So what we think of it as like it's a kind of another computer science problem, where how do you work with this kind of variability, which is a real world scenario where you're expecting the frontline healthcare worker to take a picture, and you expect that to be of good quality for an inference, right? So in that sense, we account for those variabilities and try to also have a model. Say, for example, when a photograph is taken by a frontline healthcare workers, it can also say that this image is not good enough for interpretation, so you have to retake that image. So in that sense, you can also use AI to even judge the quality of the image that is being taken or the data which is getting
Because
digitalized.
we face the same thing. Like for the all clinicians is important. That's who is putting data.
Yeah.
And what type of data, quality, authenticity,
Yeah.
all these things. Otherwise, those who are analyzing, they are the experts, but neglecting
Yeah.
this part.
So I think that that's a very important point because I'm also a teacher of this course in AI in medical professional, AI for medical professionals. And the course is mainly to raise the awareness of, about the AI technologies. But at the same time, sooner or later, the clinicians will become part of this revolution, and where they contribute in generating those data sets, which will eventually end up in developing technologies. So they should understand the nitty-gritties of what is considered to be a good data, right? So that is where the definition, because garbage in is what is going to be the garbage out. So in that sense, you will see that data, the quality of the data should be good. The second thing, as we were discussing, is the data should be, the model should be generalizable in the sense it should learn from, say, different ethnic population, say, different gender, different age group. So all these variations are to be there in the data aspects of it. Yeah.
Can the data collection be a simpler process or a easier process for the frontline worker to be able to help?
Yes. So so that's that's a challenge that we face right now, especially when it comes to the primary healthcare, where frontline healthcare workers are involved in it. That's why the point of care device also becomes very critical here. It's not just only the AI model that runs with that. So how the ease at which you use that point of care device, and that's where we believe that because the phone seems to be the one which everyone is capable of using. So without integrating AI-based solution into the mobile application, could be an easier way for frontline healthcare workers to do any kind of screening. Yeah.
Just a thought that rather than improving the quality of imaging by the healthcare worker, can we not advise something to the phone manufacturing to improve the quality of lens and thing, which can help
So,
us in this healthcare industry?
yeah, so what Vinod said, the frontline healthcare workers, the ASHA workers and the ANMs, they are all equipped with phones today, and which means with AI technology, advanced screening or if not diagnostics can reach everywhere easily. I mean, that's a huge plus that was not there before. Yes, it definitely depends on the quality of the images. Good thing is, today they say the mobile phones sell for the camera, not for anything else. So the camera technology is very good for selfies and group pictures. And so the challenge for the technology developers is how to use that. I mean, the kind of feedback he said improving from the workers is instantly. If you say no, this picture is not clear enough, take another one. It's not that they need to do anything very, they need to learn something new, then it'll fail. But just take another one, give more light or something like that. If they can give
Patients are taking selfies. Yeah. So they're sending selfies. So you have to ask somebody else to take the picture, because otherwise the picture, one, it's rotated. So and the secondly, it doesn't focus on what we want.
And also this, I mean, in the context of improving the images that has been taken at a low resolution is a classic problem by itself, because if you look at all the low dose CT scans, being taken to reduce the exposure, they all work in enhancing these images. So there are also technology where if you take a very low quality image, you could make an effort to improve it also. So that technology is also available. Yeah.
First of all, thank you so much for having me here and to be at a prestigious institute like AIMS. I think the AI in healthcare in general is on three pillars. One is the clinical pillar, the other is the technology pillar, and the third, often missed one many a times, is the economics, is the business pillar in terms of what it solves as a problem. I probably represent that the most, though I'm an engineer from background, but I help companies commercialize AI products or design AI products in the first place, which can solve a problem in a profitable manner for startups and other those. So I kind of work at the intersection of whatever we have been discussing a lot, and that gives me a different kind of vantage point in terms of view on what's working and what's not from a industry's angle. I think before I really get into any particular questions, but AI in healthcare, if I just give a broad picture of what's happening in AI in healthcare from a global perspective as well as India, I think AI in healthcare, maximum, there are about 950 FDA approved AI devices in healthcare. 75% of them are in radiology, right? And the reason for that is that AI by nature depends on the quality of data, and at the same time, the low-hanging fruit is pattern recognition. And if you marry these two, what happens is that radiology comes as someone who has been gathering data in a systematic manner, probably more tech savvy modality in that sense because of PACS evolution and stuff like that, and which allowed really the engineers and the clinicians to work to get a lot of those. So first of all, the point that I'm trying to make here is that AI is not equal yet to all in terms of modalities. There's a long journey here. Second is important point to bring out here is especially sitting in a medical colleges is that AI's use is not only clinical in the healthcare domain, right? There's a lot of non-clinical use of AI as well, which I think the budding doctors especially should be made aware of. Because at the end of the day, the problem that we are trying to solve, if we take a bigger picture, is that we will never have enough clinicians of any kind, any specialty, to serve the needs, right? And I say that for globally, it's not just an India issue. To just give you a data point, right? 20 to 25% of the radiologists in the world, 20 to 25% of the radiologists in the world sit out of US, right? So just 300 million people, 25% of the entire radiology, they still feel, and rightfully so, that they don't have enough radiologists because there is a burnout and they're not being able to cater to that population when they have 20 to 25% of the world's population. There are 200 radiologists in Kenya. There are more lions in Kenya than radiologists. Right? So this will never be enough. The point I'm trying to drive is that there's no way that we can have, and this is true for most other specialties as well. I mean, this is just an example of radiology, but it is true for most of the specialties as well. We'll never have enough. I think one of the role of AI is to scale the skilled. And when I say that is if today a radiologist or a dermatologist or an oncologist is able to serve 100 patients a day, I'm just giving a number, it should become 1,000, right? Because we'll never be able to manufacture as many radiologists or oncologists required for the imaging needs or for the clinical needs of the world. There's an important element to understand what it does clinically and also what it does non-clinically to improve the productivity of each of those frameworks, and then understand that, right? So that's one big point that I wanted to make. The other discussion that has been happening till now that I've been hearing about is from a paradigm of whether AI will replace a clinician, right? I think that's a wrong paradigm to be at all in the
Yeah,
first
that's
place.
definitely. Yeah, why I am discussing this is a forum. We should pros and all these things should see. Definitely AI non-neglect. The AI is already coming, that will be there. But simultaneously, we have to be cautious about because now you see the legal aspect, patient's atrocities, individual patient care, personalization of medicine, all these things when we are discussing, these points should be also discussed, how will you address? Because everyone is like catchy, all the technology, but man behind each machine is very important. That points
Absolutely.
should be taken care, and that should be these are the points. See, someone like I am giving my example when we do one database, we are involved, showing when we presented in a conference, okay, so good, I'll do it. But no, not easy because we are involving our residents as a training system. They are putting data, not the data entry operator. That's why the data analysis, when you see the result is different. Yeah? When someone putting data entry operator, we are getting the result, we'll do. 15 become 25. Just example. The same way this, because AI is totally data dependent. Most important, this should be a very clear and analyzable data should be there. So who is putting? That is very important. And a teaching institute, involvement from the residents, they should be involved in that thing. They will take care of the points. They will involve. They will evolve. These things should be discussion. That's why I putting these questions here. Yeah.
Sir, I am working in AI last 3 years and I am learning the fundamental of AI as a clinician. What I get experience from out of that, I am just want to share with the audience. Actually, I am doing some systematic review, almost 10 systematic review. Out of that, 3 are, 2 are almost in, one is published, one is revision, and 2, 3 are in underline. What I seen, there are very few academic study from India. And the most of studies from Western countries, from Japan, China, and USA, and that most of study are retrospective in natures. And other limitations from that studies, most of the study are seeing only the one parameters, only the unimodal. So I want to try to address this. Most of the clinician also making the hype. Everybody is going in AI without understanding the fundamentals. Because when I try to read the paper, I not even understand the terminology. Then I decided I have to understand. First, I have to learn the fundamental. Like before become a physician, we have to read anatomy, physiology, and biochemistry to understand the disease pathogenesis. In the same way, I request to all younger clinicians particularly, if you want to learn the AI, first learn the fundamentals. If you don't learn the fundamental, directly you just read the terms machine learning, deep learning and AI and other generative and other type of subset of AI, then you will have a surface knowledge. You will never interpret the things. The one thing. The second things, the sir, you already discussed about the data, ethical issue in the data. There is one concept that is called federated AI. The federated model is work, the principle like we have we can do some, particularly it's problematic when we are doing the multicentric study. Sharing of data, we are fear and sharing of data. So to solve that problems, we can make a centralized the computer-based program that your data will not share, but only the algorithm or only the calculation and data can be deposited at their individualized centers. But you can train the model as a joint at a single. So this model is called federated model. This is very helpful or it's evolving. The now two more concept like generative and explainable AI. Because people, AI, the architecture like CNN and RN, these all are the black box. These are the best on the neural networks, and this is very previously it's evolving models. So people don't know how it's working. It's okay or not. But the most of the models, there is no any performance metrics properly. They just did sensitivity and specificity. They don't did like other performance metrics like F1 score, accuracy, AUC, RSC curve. This is very, very important. Even they do not did test internal validation, external validation, because people don't know the terminology, just going with the AI, making AI like that. I am also working in AI. So my humble request, I think if we want to learn, we have to know the fundamentals. Second thing, if any institutes want to do work in AI, there is need of some scientist, data science scientist and Python experts in our institute itself. Otherwise, we will never develop any good model that can be commercialized.
So what you are telling, this is right, but this is an idealistic thing, is not always a practical. No? This is the important. That all the things has been gone. What you are discussing, that is each institute, like in AIMS,
Yes.
is not possible. Like in medical college, this is not possible. Here the discussion is, these are the points, individual level, how they will take it,
Yes, sir.
and how will it proceed.
Yes, sir.
Yeah, what you are telling, this someone is not realizing what is data, how we can discuss with the AI.
Yes, sir.
Yeah,
Yes, yes.
these are the points we are telling. They are the experts, they are giving, because they are those who are working.
Yes, sir.
These are the points should be discussed. And over the years, we will evolve.
Yes, sir.
So,
Yes, sir.
so 2 points. I mean,
Thank you, sir.
quick. Pardon me for advertising for what we do a little bit. One is this data foundation that I mentioned already, that was supposed to be a repository of data that anybody can use, with including the federated facility. I mean, authentication, privacy, what about the state of the art available in technology in privacy or authentication or access control, etc., as well as federated learning. The vision is to provide all that so that AIMS or some other institution don't have to do their own, big setup here. We can be the back end for those people. That, and second, the first part you asked, IIIT with along with NAMS has been running a fundamentals of AI and ML for medical professionals course, an online course. The first cohort, we know this teaching that. Today is the 9th week of the 12th week of 12-week course, and we will have a next offering from January or something. The date will be announced. So, I mean, yeah, I think all clinicians, all doctors should be familiar with some aspects, so that if not to, like he said, participating, creating no data, at least when they talk to new AI solutions, somebody presents, you should be able to at least ask the right questions back, etc.
Yeah, that's what I want to suggest. NAMS has already started this online certificate course, and this is a time for people to encourage people to join this. This is something very
Wonderful initiative.
yes, and
People are-
also last actually this April I did a midterm conference of the NAMS. Then theme was role of AI in healthcare, and with that, after that we also decided to have AI cell in every medical college, and I'm sure AIMS Jodhpur can also have a AI cell in the Jodhpur Medical College. So Jodhpur here, so that it can actually help so many people to make use of AI, and is a wonderful opportunity for NAMS to start the AI course.
More point. Any questions?
Yes.
There's one question.
Ma'am, this is regarding your app, ma'am. Ma'am, you have used patient data for training your model. In that sense, how ethical is it using patient data for our commercial purposes? What is the legality behind it? Can this be done to create data sets in hospitals, or did you take specific consent for the particular model?
I just submitted it to the ethics committee. This is the project which is funded by our association, the Indian Association of Dermatologists. So we have submitted the project. It was discussed in the EC meeting this month, November, and they've come back with queries. So we are now working with our AI scientists, and we'll get back to them. Yeah, there are earlier there were these issues were not there. See, most of the pictures which we use, we usually get a consent signed by the patient. So whenever we are taking pictures, we have, like, I have an undergraduate textbook which is used, and I have taken pictures of the patients, and I have consent signed, and that I will use it for scientific. And when I took pictures, AI was not there in the picture at all. You know, it's 20 years, 30 years back, nobody talked about AI. AI has come up in the maybe last decade. So the consents do not include, that this will be used to train artificial intelligence. The consent just says that it will be used for teaching purposes and for conferences. So I think we have to now, I think there is a policy now in AI, and I think I will not be able to respond to that question. This thing, I think the people in the AI would be able to answer that.
Yeah, the ICMR has come up with new guidelines on AI in healthcare, so which talks about how data has to be handled when it comes to building any software devices. So in that sense, data anonymization becomes critical. So even though there are possibility of some information, specifically if you talk about imaging data sets, if any patient-sensitive information is there, then we have to make sure those information is removed before it has been handled by any engineers. So that's one of the important step when it comes to sharing of medical data. And some of these electronic health records, which also being used in the context of predictive analytics, we also have to come up with newer ways to mask some of these informations where you cannot trace back the patient information from any of these databases. So these are very critical steps being used by us to build any kind of solutions now.
Sir,
Kapil?
is there any specific consent that has to be taken from the patient, or only proper randomization and masking is enough?
No, so in terms of the retrospective studies, right? So, we get a waiver in the context of ethical clearances. But when it comes to prospective studies, so we have a proper consent form, which every patient will be explained in their own language, which they sign before participating in any of these studies. Right?
Thank you, sir.
Yes, Dr. Kapil, last comment and closing.
Last question, sir.
Closing comment by you.
Do we have any app which has been used actually in our country for public health system or clinical system?
From AIMS, we had a departmental study. It was an MD thesis, and subsequently there is a PhD going on, dermatological diagnosis. And they had picked up 40 common dermatological conditions. I think there are 2 publications from that. So that has been validated. So the app was developed and then validated by a private practitioner who was a dermatologist, and I think in the community by 2 non-dermatologists as well. And that was
Madam, my question is not with a small institution.
yeah, but
My question
this
is
was the
for
big-
at the national level, regional level.
So we were also trying to, develop an app that to be used by ASHA workers for doing this and that. There are, and we were told an ASHA worker's phone today is expected to have some 21 apps or 25 apps or something. So adding more apps is not a solution, because they are confused. Yes, I think your point is valid. There should be a good way of creating an app that that goes to actually to the villages with the rural level practitioners and does something. But that's a very big problem. It's not an easy one to solve. No app is available
Sir,
today.
not for the ASHA workers. I'm just talking about even the group of clinicians or physicians or a
No,
cardiologist
I-
or radiologist. Do we have any
No,
app?
Sorry, is the question, are there any AI products being used in India by clinicians?
Yeah, of course.
Oh, of course, yes. I mean, there are many AI products being used in India, which are there. Machines, even without machines. So to just give some examples. So for example, there is a solution in stroke called Rapid AI is being used in Apollo, in many other hospitals as well.
Okay.
And not
What
just
happens
one.
to the false positive diagnosis by these apps?
The accountability remains with the clinician. The accountability is never transferred to the program. You cannot sue this app, you cannot kill the app, you cannot do anything to that. I think what we confuse many a times, and that's was I was trying to make a point earlier, was that clinicians will never be replaced by AI. People make a confusion between job and task. A job is something that you are held accountable for. Task is something that can get replaced. Job cannot be. So the clinicians, it's not a replacement, it's a tool to help the clinicians do more and more accurately, right? Absolutely.
Yeah, so I think so most of these products are augmentative in the sense of enhancing the clinical decision-making skill. So in that sense, for example, if I'm a radiologist who's looking at the X-ray or CT scan, right? So the AI model only shows a region of interest, but does not draw any conclusion on it. So in that sense, I would say the decision making is still in the hands of the clinicians, but this is only augmenting his clinical decision making skills, right? So.
Thank you. Thank you, every panelist. And the audience, I want to close this session. Wonderful session and wonderful future, promising future for the healthcare industry. Thank you once again. Thank you.
Thank you, panel, for the wonderful discussion. So I request the chairpersons to felicitate our speakers. Professor P. J. Narayanan. You're welcome, sir. Dr. Vinod P.K. Dr. Neena Khanna. Mr. Amit P. Gandhi. I request Kuldeep sir to felicitate our chairpersons. Now moving forward, we start with the most awaited session, that is biomedical science and regenerative medicine. So I request Professor Kuldeep sir to come forward as a chairperson. You're most welcome, sir. Thank you, sir. Now I hand over the session to our chairperson.
So this is our last session of this conference, and one of the very important for in the form of innovations and also the future of the medicine. And this topic is biomedical science and regenerative medicine. Now the collaboration which can be seen between the medical institutes and engineering colleges now coming up. And for this, I would like to invite Professor Ashok Kumar, who is the director of IIT Kanpur La Trobe University Research Academy, at the Indian Institute of Technology, Kanpur. So he will be speaking on the biomedical science in the regenerative medicine and how it can help the future of medicine. So it will be interesting for everyone, right from the anatomy to the neurosurgery. Dr. Ashok sir.
Actually for inviting me here. So I have a great pleasure of speaking at Namscon a couple of times before also actually, and this is a very relevant topic actually from the cooperation between the engineers and the medical fraternity. So what the topic biomedical sciences and regenerative medicine actually, of course regenerative medicine people very well understand actually the subject. It's not something I should say new because we know it actually from ancient times. So that there is a regeneration actually, and these regenerations, even if these were as myths or these were the fictions actually to be understood, but then these have become the reality actually. Just an example here, if you see that's a phoenix, so which is a sort of myth here, so which shows that it can reborn from its ashes back, which means there is a regeneration and there is a revival actually on that. But then there's a Prometheus, many of you may be aware about that. It's a Greek mythology actually, which means that liver regenerates every day actually if it is eaten by the eagle actually, so the next day actually you will get it back. So that's again a sort of condition actually where the regeneration is possible to happen naturally actually. But then we have also actually the natural regeneration actually that can be seen in the limbs of the newts, which can come back on its own. But humans have always been fascinated actually by revivals, regenerations, and cure. In that context, actually, if you see in a sort of fiction here, which is Carmen Ryder's fiction, actually, which means that the arm which is cut, actually, it has to come back, actually, and that's compared actually with the newts, actually, and liver almost has it. But taking these stories, you call it actually, or the myths, now the period actually where there is an intervention actually, where you can just now be able to actually regenerate the vascular grafts actually you can have, you can have the skin grafts actually, you can have the bone scaffolds and all actually. So they can come back actually, and you can have the external intervention in all of these. So let me give a little bit brief actually what is basically happening in this case actually. It's a tissue engineering concept actually where you have actually the cells, and these cells basically can be grown on a scaffold system actually, which is what our matrix in the body is. And you implant it back actually, and you can get a tissue back in that way actually, and you can completely have a regeneration of the whole tissue, or even you can develop a sort of complete organ actually. So that's a tissue engineering aspect actually, where you can apply also the engineering concepts on that actually. If we look into the path of overall actually how the regeneration has evolved actually with time actually, it's a old subject as I said actually. So we are talking about 6th century actually, when we have Sushruta's surgery being established actually with a rhinoplasty of autologous skin grafts actually for the nose actually. We start from that actually, but those were majorly actually from the autografts actually. But then this has evolved actually with using the skin grafts actually from the cadaver. Then you can have actually simply cell sheets generated like the skin sheets of keratinocytes actually. But actual concept of tissue engineering was only established in 1987 actually, when the first time it has been shown actually that you can have ectopic tissue just developed at the back of the nude mice actually. So where you have a concept of actual matrix and actual tissue regenerated on that actually. But then 21st century actually has seen how the tissue engineering actually can have real application actually when we have the lab grown, the organ is developed. Then we have the 3D printing coming up actually, which has shown a lot of potential actually, and many of these areas has further grown up actually in that. So we are at a stage where it is possible to regenerate any type of tissue actually, or to develop a complete type of organ as well actually in the laboratory condition actually. But let me take it, if this was the situation actually, but then where are we right now actually on, the application part actually, or in the clinics on that actually. So this is a classical time frame of translation potential of regenerative therapies. So this is how a basic researcher actually in an academic institution is actually try to do. They start actually with biofabrication actually, what you are seeing it on the diagram here actually, and then you can also have a sort of, where you can just develop it from the structural point of view, and can use also some bioactivities and characterize actually the materials. But then finally taking it the clinic, you can see very well there's a gap. So that gap is basically taking this translational phase a longer time. So this is what right now the efforts is actually, that how we can collaborate actually with the clinicians actually, with the medical fraternity actually, and also the industry actually, and how this gap can be bridged, almost how we can just remove this gap basically actually. That's the purpose actually, what even this collaborations actually with the clinicians actually are being looked at actually. For that, you have to be on board actually with the industry from the very beginning. The clinicians have to be from the start, and the right type of materials actually are to be looked at. So that's only possible actually when the clinicians and the engineers actually in this domain can work together actually. So I think this is a background actually, which I thought I just, get you into that actually. And then what we are doing on this area actually is, as I mentioned actually, that we have the extracellular matrix. So this is what we do at IIT Kanpur actually. We look into this matrix for developing them as scaffolding system actually, but we take this phenomena from the nature. So this is what you call it as permafrost actually, and you develop the gels actually in this manner, which is porous, and these porous gels can be seeded with the cells, and then can be implanted to the tissue of site actually where the regeneration is required. But these fabrication methodologies, fabrication techniques have been advanced actually. You now have the 3D printing actually, which can give you most precise dimensional structures, architecture actually what is required. Electrospinning is another approach actually, or microfluidic techniques actually, which are all engineering techniques which is applied for developing the matrix actually, which is the matrix of our body actually. So we mainly work in these domains actually, but that's how actually we are applying these type of materials in various applications, where we have looked into bone and osteochondral tissue engineering, cardiac, extracorporeal bioartificial liver, spinal cord injuries, and also peripheral nerve injuries, hemostatic bandages, and gut microbial restoration and mucosal healing. I just would like to give a little bit of idea about that actually. So how, in the case of cardiovascular disease, we are taking the coronary artery diseases, which is mainly the thrombosis, atherosclerosis, and myocardial infarction. Actually, we understand actually that you have a hypoxia condition where the oxidative stress and cardiomyocytes death happens, and fibrosis ultimately results in the myocardial infarction. Actually, but what is our engineering interventions in these three different type of conditions of coronary artery diseases? So we design the patches which are elastomeric in nature actually, and these can just be mimicking to what the muscle of the heart beats in that manner actually, or we can have actually polyurethane based actually, which is containing also some type of antioxidant, and you have also something actually which is needed actually for cell proliferation, or you can have some injectable type of gels actually. But generally, the variation of these in the format point of view is question of actually how you want to apply them. But they are all basically the carriers of the cells or carriers of the bioactive agents actually. So of course, we know it's not just question of just using the cells along with the material. We need to have also some type of bioactive cues for that actually, so that you can have a possibility of regeneration point of view. We use the exosomes, for example, here. These are the exosomes actually which are isolated from adipose tissue, or we can also have actually from the cardiomyocytes actually these vesicles. which can be used for that. What we did here, actually, how did we dissolve the clot in this case, actually? And we took here carotid artery of an animal and just generated a clot of just, where you have actually the thrombosis happening there. And then we injected with a responsive polymer, which is containing a drug like streptokinase or urokinase, or it can also have the exosomes, actually, where from the same cell type which is producing these enzymes, actually. And they are not basically digesting the clot, actually, but they are resorbing the clot, actually. That means there is no further clot formation, actually, on this, and it's a localized effect on that. So one can see the effect here. I will not go into the detail of this. So we studied this with finally, actually, with ultrasound, actually, M-mode ultrasound, actually, and we see the clot formation has been removed. And then there is also, just healing of the endothelial lining, as well as under the endothelial lining, actually, which is expressed, actually, by the markers. In the case of atherosclerosis, actually, or can say, actually, the grafts what we use, we just have a sort of tri-layered graft, actually. So where you have the middle layer, which is giving the strength up to the graft, but these are all polymer-based grafts, actually. But these are also the carriers, actually, for some agents, actually, which are needed in the case of where you use the allografts, actually, or you use the coronary artery grafts, actually. So in this case, actually, we have these just having the 3 layers. Oxygen releasing is one of the material, actually, which is property of these layers there, actually. And then you have gallic acid, for example. So gallic acid has an advantage of that it doesn't allow the smooth muscle cells, actually, to create a stenosis again onto the stent, which is a problem, actually, of the current type of, what are the, these stents being used, either coronary, stents, actually, or simply the, which are used as a graft, actually, for vascular, recovery, actually. This is how the structure is. And again, these were studied by, ultrasound, actually, and the ultrasound clearly shows, actually, that we have a complete opening of the size of this, actually, and then you have the representation of what the smooth muscle cells are not proliferating there, actually, and then you have the healing of also the endothelial lining on that. So we went into a system, actually, where we have the same type of material and make a patch of this, actually, for myocardial infarction, actually. So this is a model here, actually, where we generated a myocardial infarction, actually, by just have a sort of, ligation in the left ventricular, actually, descending ventricular, artery, actually, and just created a sort of fibrotic tissue on the cardiac muscle and put this patch of polyurethane, because that's an elastomeric, actually, and that's containing also oxygen releasing property, and it's also containing the exosomes, actually. So we wanted to see, actually, if we can just regenerate, actually, the damaged cardiomyocytes there, actually, and also the tissue on this, actually. So this will be seen on wait, it's not moving. Yeah, sorry, so it was not moving, actually. So this is how actually it looks like. So where you have basically the recovery of the fibrotic tissue on the cardiomyocytes directly, or the muscle, the cardiac muscle. So just by simply using this patch, along with the bioactive cues, which is here used as the exosomes onto the material here. Of course, I mean, we have been in discussion, actually, with the surgeons on this. So presumably, they have suggested that, actually, we should have a sort of minimally invasive approach rather than completely opening the myocardial cavity here, actually. So we just then pericardial not to open that, actually. So we just have a sort of here the liquid form, actually, in this of the same material, which can be just injected at the same site, actually. So what we are now actually working on that part. So the second area, actually, is neuroregeneration, actually. So there are two important, one should say, actually, that how the materials needs to be developed, actually, for neuroregeneration, actually, whether it's a peripheral neuroregeneration, actually, or even we have also gone, actually, into the spinal cord regeneration, actually. So what we see, actually, is that there is a conductance, actually, which is essentially needed, actually, for any type of RAP. what you are basically using as a wrap surrounding the nerve which is damaged, where there's a compression or there's a complete truncated nerve also. So we took several of these models, and just based on that understanding, what we did, we just induced the conductance by using graphene oxide, reduced graphene oxide. And again, they will also be used some drug molecules which are essentially used in the nerve recovery in that. So, and second part was to have some sort of alignment in these materials because if you look into the nerve extensions, they generally will need to have a sort of path to just extend into the direction where you have the loss of nerve. So these materials are designed in that fashion that they can get a connectivity if you just make them aligned in one direction. And these materials are designed in that way where you have the alignment in one direction rather than having completely a sort of random type of pores in that. And we took some of the examples for that. This is the median nerve of the hand. If this gets cut, then obviously you get a carpal tunnel syndrome. So is there a way of maybe recovery of that? So we make this conducting wrap, which is containing graphene oxide, which can stimulate with the conductance. And we simply have that and just used for the rat model, and we could get the recovery of the damaged part of this nerve back, which is shown by the histology and immunohistochemistry analysis here. Not going into that part in detail here. So of course, we took also peripheral nerves. We took even also the diabetic neuropathic conditions as well. So even in all of these, this type of approach has been seen to be working successfully. So we use it not in particular for the diabetic neuropathy. Obviously, it's not just simply localized type of effect. We have to use it systemic in that. So that also we did. But more challenge was to see what can be done on the spinal cord injury. So when we had truncated the model with the spinal cord injury, so in that case, there's a damage both to the spinal cord as well as to the peripheral nervous system. So both of these conditions were to be rectified. Again, in this case, we have a soft gel. This nature for the spinal cord has to be somewhat different than you use for the peripheral nerves. So it's a more soft gel with an alignment. And then you use the conductance. The conductance was basically shown to be the most powerful tool here, giving a conductance at that point of time. And we used also the epsilon B, which is a neuroprotective agent. So the combination of the material and you can say the topographic cues and the electrical stimulation has shown the potential that we can have the recovery of these there. This is what you see in this. Again, I'm not going into this histological analysis here, but all these show the recovery of the spinal cord injury. So I will take the last part, which is majorly, since this part, most of these, technologies and materials have gone into the clinics as well as have also, been transferred to the industries. So this is more to look into the bone pathologies. So we are not talking about only the trauma condition of the bone, but we look into the various pathological conditions of the bone. Can it be osteomyelitis, osteosarcoma, or even the osteoporosis, how the approaches basically can be used and what type of materials we want to see. Because it is not just one single material to be applied for all these conditions, but our base material is indigenously prepared, that is hydroxyapatite based the material, which acts as a carrier. It acts as a carrier, if we have to use some antibiotic, acts as a carrier for antibiotic, or if we have to use any type of drug, it acts as also a carrier for the drug. But besides that, it has also to do the regeneration. So because if you have osteomyelitis condition, obviously you may have to recover the infection part there. But at the same time, we need to have a regeneration also in this condition. So these are all the types of materials. Well, the material, base material, as I said, is hydroxyapatite. But then we make a composite of that, combine with the polymers and use different type of technologies. Like we have the printing technology being used on this, so that we can have a recovery of the conditions which are there. And then these are again the examples which I will not go into detail. But yes, various model systems which I show, which obviously the orthopedic surgeons come across a condition. You have an osteoporotic condition, but then you have the hip which is infected. So then what type of approach actually which one can use? You do hip replacement actually. Obviously it goes into the contralateral part actually. Then what is the protection actually of the other approach actually? Can we also treat the other hip, not surgically, but minimally invasive manner actually by just injecting actually these materials? And what is the outcome of that actually? So these are the strategies as well as the materials actually which we have been developing on this. This is a case of osteosarcoma situation actually. So obviously you have a tumor that has to be removed, then it has to be killed actually with the material. But that is not the end of the story on this actually. Then you have a major part actually which is periosteum actually, which needs to be generated actually. So periosteum generation actually, we have the approach of making the film along with bioactive cues, which can regenerate actually the periosteum part. So tuberculosis was the major concern actually, and we have got a big program of bone tuberculosis, particularly looking into the spinal tuberculosis actually. So what is the approach actually? How should we deal actually with the spine tuberculosis actually? So we took the material actually and just having rifampicin and isoniazid actually, and have a localized TB created actually in the spine, and try to treat it with the material actually which I mentioned actually, hydroxyapatite actually, and this hydroxyapatite plus calcium sulfate becomes a pillar. So it sets in actually in 15 minutes as an injectable pillar actually. So this is what actually we did, and we got a complete recovery of the infection as well as regeneration in that. So I think I will skip these because my two students have presented this work actually. This is related to the NFLD actually, which is MSLD actually, and MASH, how we can be reversing these conditions actually by using these approaches. So another condition was to look into how we can have actually the delivery vehicles for inflammatory bowel disease conditions actually. So whether it's a probiotic vesicle actually, or it is any other type of immunomodulators actually, what that can be looked at. So what is the definitely the focus for us actually right now? What we are trying to see actually, we are working on this part actually to just have a storage and transportation of the organs, and how we can take them actually to the with a time gap of what is desired actually. So we work on a sort of dynamic system actually, so that we can keep the organs live for a longer period of time actually for that. But at the same time, we try to design actually our own organs actually, which can be used actually for the application part actually. I think together is together. So we have to be together in all of these actually, and I have to obviously I have been mentored actually by really the people actually, and particular for the regenerative medicine actually. This is a field actually which I have been introduced actually by Dr. Sareen actually. So he was basically behind for this whole actually, and all others people actually who have been behind for our activities actually. Thank you very much for the attention.
Thank you, sir, Professor Ashok Kumar, for a very vivid presentation about regenerative medicine and the future of medical science. Although we have amongst us plastic surgeons, orthopedic surgeons, and the students also the future who are going to see the future. But because of lack of time, we can have few questions from the, if there is any question from the audience or comment.
This is not a question. This I am very fascinated that how you are regenerating the neural tissue and what is the functionality.
Yeah. So we have gone up to the preclinical stage. That means actually we use the rat models actually for that. The functionality is completely recovered actually, both in the peripheral nervous system actually, as well as in the spinal injury actually. And the approach I mentioned actually, we have majorly used with the electrical stimulation actually. So we have the materials actually which are conducting materials in nature. And when we insert those materials at that gap, even the gap of 1.5 centimeter also we created. So
this will be very good when futuristic vision, because all spinal cord injuries, you can the paralysis, all these things. But that stimulation you have to monitor actually.
Yes. So that obviously actually is to be monitored actually, and anyway actually this has to go surgically. So that time actually when one gives a sort of stimulation actually, that becomes more effective, because then you are giving actually to the tissue directly that point actually. But then after you close it actually, you can also be able to give through the muscles actually the stimulation actually. But that's the first part is very critical actually for the stimulation part. But epsilon also we use because that is neuroprotective actually for that. So that's what normally nowadays actually they use actually. But in this case, as I said, actually, we like for example, we had 10 animals actually. We have a sort of fatality, we have some mortality of 4 or 5 animals out of that. But who survived actually, who got the recovery actually from the peripheral nervous injury, so they completely recovered back.
Completely recover.
They completely recovered
Fantastic.
back.
Thank you.
So surgeons are at the forefront of regenerative medicine, and I think the technologists are they are coming and holding hands with the clinicians working in this direction. Actually, just I would like to comment that on the first day, second day, we had the pre-conference CME on One Health,
Yes.
and I invited the veterinary scientists also here. So they are veterinary scientists as well as veterinary clinicians, and they were good clinical surgeons. They are doing on the pets and the wild animals. They have operated on the lions, deers, cats, and frogs, and every animal they have operated. So I think joining hand and collaboration is what is the requirement for the future. And I think your talk, whatever Dr. Carr is saying about the regenerative medicine and how it can be safely used in the human beings,
Yes.
is to be looked after with the technological advances, which is a disruptive science. And the disruption which has start happening is going to make the life of the people easier, but at the same time, ethical standards and the safety and precautions to be followed. So I think in this direction also we have to do parallel work in this area. Your talk was very illuminating, and I think we can now, and we thank you for your talk. We thank all the audience for the patience listening. And I think we'll get a lot of food for thoughts for integrating the regenerative medicine with the AI, with the clinical medicine, and also One Health concept. The concept of our conference was successful. One Health, let us collaborate to take care of our health. Thank you, sir.
Thank you so much. Thank you.
Thank you, sir. Thank you for the very thoughtful and insightful presentation. I like to request Chairperson, sir, to felicitate our speaker, Dr. Ashok Kumar, sir, Director, IIT Kanpur. You're welcome, sir. I request Dr. Naresh Nevnani, sir, to felicitate our Chairperson, Kuldeep, sir. Thank you, sir. So our director, sir, GD Puri, sir, is on the way. So we'll be starting the valedictory ceremony in few minutes. Thank you.
Good evening, everyone. We hope that these few days at Namscon 2024, organized by AIMS Jodhpur, have left you enriched with insights and lasting memories. I invite Executive Director, AIMS Jodhpur, Dr. Govardhan Puri sir, Secretary NAMS, Dr. Umesh Kapil sir, NAMS Council Member, Dr. O.P. Kharbanda sir, Organizing Chairperson NAMSCON, Dr. Kuldeep Singh sir, Organizing Secretary NAMSCON, Dr. Pankaj Bhadwaj sir, on the dais. Thank you. The 64th NAMS annual convocation is a convocation of pre-conference workshop, national CME, and scientific conference based on the theme, One Health, Let Us Collaborate to Take Care of Our Health. Now I invite Dr. Kuldeep Singh sir, Organizing Chairperson, NAMSCON 2024, to share a few words and officially begin the valedictory function.
So thank you. So on behalf of All India Institute of Medical Sciences, Jodhpur, and National Academy of Medical Science, which is this is a part of this NAMSCON 2024 with the theme of One Health, Let Us Collaborate to Take Care of Our Health. From our side, we felt that it was wonderful from day one to with the workshop, 2 workshops on midwifery and the health technology assessment, to the second day of National CME on One Health, and then next 2 days of invigorating academic feast and a lot of contribution from multiple disciplines, and there's a lot of discussions, and it has all been recorded as well as it was streamed on the YouTube. So it can be seen anytime later on also if you have missed the session. So with these few words, I thanks our Honorable Executive Director, Professor G.D. Puri, for giving us permission for this conference and also as a patron of this conference. And also Council Member Dr. O.P. Kharbanda and Dr. Umesh Kapil as Honorary Secretary of NAMS. And the most importantly, the credit goes to Dr. Pankaj Bharadwaj, who is the Organizing Secretary, and his team of MPH students who have contributed immensely for this conference, and all the students and the PGs and the faculty members of AIM Jodhpur. Thank you.
Thank you, sir. So we start with the first theme, that was MediQuest. It was an online quiz session that was organized, and 490 participants from 21 states and 5 union territories took part in that. It was conducted online, and the winners were selected from the top 6 scorers. So the second runner-up award goes to Dr. Omar Afroz, SR Secretary, AIMS New Delhi. The first runner-up award goes to Dr. Kartikeya Chaturvedi, JR Secretary, MGM Medical College, Indore. And the winner is Dr. Arun Ghosh, JR Pharmacology, MAMC, New Delhi. A big congratulations to all the winners. Now we move to next category awards, poster presentation. We had received 29 entries for poster presentation. I request winners to come on stage and receive the awards. So now I invite all the dignitaries on the stage. The second runner-up award goes to Ms. Prabjyoti Pahwa, Department of Molecular and Cellular Medicine, Institute of Liver and Biliary Sciences, New Delhi. The first runner-up award goes to Dr. Tanuja Raijal, Medical Genetics, Department of Pediatrics, AIMS Jodhpur. And the winner is Dr. Chandra Prabha, School of Public Health, AIMS Jodhpur. A big congratulations to all the winners. Now we move to next category awards, oral paper presentations. We have received 48 entries. I request winners to come on stage. So the second runner-up award goes to Dr. Apurva Mittal, MPH Scholar, School of Public Health, AIMS Jodhpur. First runner-up award goes to Ms. Triya Saha, PhD Scholar, Department of Biological Sciences and Bioengineering, IIT Kanpur. And the winner for oral paper presentation, Dr. Babulal, Assistant Professor, Department of Trauma and Emergency Medicine, AIMS Bhopal. There is one appreciation award for the excellence performance during the oral paper presentation by a third-year MBBS student, Ms. Aishwarya Jain. Yes, the certificates are e-certificates and will be shared by the organizing team. Now I request Executive Director, AIMS Jodhpur, Dr. Govardhan Dutt Puri sir, to share a few words.
Good afternoon. I am now feel little relieved that we have successfully completed the 64th annual conduct of the 64th annual conference of National Academy of Medical Sciences. First of all, I must thank the council members, the president, and the National Academy of Medical Sciences as a whole for allowing or allotting us to organize this meeting in city of Jodhpur at Institute AIMS Jodhpur. And I must thank my previous director here, Dr. Kaur, whose efforts bore the fruit that this conference was allotted to this institute. And it's all efforts of Pankaj and Kuldeep. I was just standing at the back. and they only did all these things. But wherever they had difficulty, they'll just push me front so that I could bear the brunt. So anyway, it was a great experience of organizing conference of Namscon and especially the convocation, which was quite a tough job because of the VVIP being the chief guest of that convocation. But overall, we all enjoyed, and I'm sure our team, AIMS Jodhpur team, took care of all of you, those people who are here. I can understand they were happy, that's why they're still here. But those who have left before, I'm sure they also have been very happy. So if there are any deficiencies, please excuse us. And whenever we'll have other opportunity, we'll make sure that we cover up all those things. With this, thank you very much. Long live Namscon. Long live AIMS Jodhpur. Jai Hind.
Thank you, sir. Now I invite NAMS Council member Dr. O.P. Kharbanda, sir, Pro VC Ramaiah Medical College, to share a few words.
I think first of all, I must say good evening to all of you. And thank you, all of you who are here for the end of this function. Thank you very much. Organization of a convocation of this magnitude and a conference of that very disciplines, coming people from India and also joining from abroad is not easy. So I must compliment our Executive Director Puri, Dr. Kuldeep Singh, Pankaj, and the entire team. And on behalf of the National Academy of Medical Sciences, I like to thank them for all the arrangements, and I wish to compliment them for the wonderful arrangements you have done. We are all very happy, and I think we like to thank you on behalf of each one of those who are here and even those who are not here for making our stay comfortable. The other thing which I wish to say during this my visit to Jodhpur, I noticed that it's a beautiful campus. And in this beautiful campus, the weather is perfect. I think it was specially ordered for the conference, it seems like. And also, the flavor of food is very different. So we enjoyed that also. In addition to that, the flavor of the scientific content also varied significantly. We had very high-end discussions on medical education, artificial intelligence, innovation, and the speakers did a great job. And but I'm told that they are already available on the net. I think you have missed it. We can relook at them, hear them, especially the one on innovations and AI were very, very useful. And to all young people who have won the awards, my congratulations and good wishes. And once again, on behalf of the National Academy of Medical Sciences, I like to thank, and particularly our president, incoming president, entire executive committee, and our secretary, Dr. Umesh Kapil, who has a great patience. He speaks very little, but he observes more. And I think I am under observation even now. And he is doer. He's doer. He's doer. So a lot of work, and he is supported by also National Academy staff. I don't know if they are here. And all of them, thank you very much. And have a great evening. Enjoy your stay if you are staying. If you are going back home, safe journey. Thank you.
Thank you, sir. Now I invite Secretary NAMS, Dr. Umesh Kapil, sir, to share a few words.
Namaskar and good evening to all of you. First of all, my most sincere thanks to ED Sahab, Dr. Puri, Dr. Kuldeep, Dr. Pankaj, and his team. It's a wonderful experience to be here. We really enjoyed the local hospitality, the meticulous way the entire conference was done, and it's a remarkable achievement for us also that the convocation went on smoothly. There was always a small area of you call डर था कि ये convocation ठीक ठाक हो जाए. That was a main what you call our function of National Academy. Every year we do it, and it was done very, very smoothly. Courtesy all the team members and the backstage people, it went on smoothly. And I would like to say that we all enjoyed, our NAMS team enjoyed it, all the council members enjoyed it, all the guests who had come, the many guests who had come. We had many directors of AIMS, many distinguished guests we had. We had the NMC chairperson, we had NBE chairperson. But they normally do not come. Even we have one chief guest, more than sufficient. We had almost everybody was a chief guest for us. We had deputy secretary, we have had health secretary, so many people we had. And I know that it's a stress on the organizers to take care of that. But it all went on very smoothly. Thank you, Purisa. Thank you, Pankaj. Thank you, Kuldeep, sir, for organizing this. And once again, my most sincere thanks to all of you. Thank you very much.
Thank you, sir. Now I request Organizing Secretary Namscon 2024, Dr. Pankaj Bhardwaj, sir, to propose the vote of thanks.
Thank you, Neha. It is just a custom, and the vote of thanks are already been proposed by many of us. But to keep the tradition open, so it's my privilege to propose the vote of thanks on behalf of All India Institute of Medical Sciences Jodhpur team. At the outset, I would like to express my profound gratitude to the chief guest of the convocation ceremony, Honorable Vice President of India, Shri Jagdeep Dhankarji, and our special guest, Dr. Srimati Sudesh Dhankarji, for their gracious presence. My heartfelt thanks to our guest of honors during the convocation, our Honorable Secretary Health, Ms. Punya Salil Srivastav, and also Dr. Rajesh Gokhleji for gracing this event with their presence. We're extremely grateful to our eminent experts, panel of experts, and I'll not be able to read the names of each and every one of them, but yes, there was none others like our ex-DGICMR, Dr. Katoch, Dr. Serene, Dr. Aarti Serene Madam, Dr. Abhijat Sheth, Dr. Vijay Ojaji. So they were all with us, and thanks to all of them who have been the part of this. As our ED sir said, the entire journey started with Dr. Madhavan Andkar, our ex-ED, when he proposed it in the earlier meeting in Bangalore in Ramaiah Medical College, and we could get that. So thanks goes to our esteemed Executive Director, Professor Govardhan Dutt Puri sir, for his unwavering support, because the commitment made by our earlier ED was completed by or is completed by the current ED. So a round of applause to both the EDs, Dr. Kar and Dr. Puri, for supporting us in making this journey successful. I would like to express my deep gratitude to the NAMS executive bodies, including the past president now, Professor Sareen, the current president, Dr. Bera, Secretary NAMS, Professor Umesh Kapil, Dr. Rajesh Su, that entire team. We have been actually discussing all these every day, 8 p.m., though the time was a bit uncomfortable to all of us, but they kept us doing all the important discussions at the end. I would also like to express my sincere thanks to the administration, all deans, MS, DDA, FA, and their team at AIMS Jodhpur. Again, at my utmost duty to thank our knowledge partners, Department of Biotechnology, Government of India, ICMR, NCDC, NIHR, Global Health Advocacy Incubator, Sun Pharma, AstraZeneca, Sanofi, Beringer, Swarnayu, Jodhpur School of Public Health, and our event planner Divine for their unwavering commitment. A special note of appreciation I would like to extend, ladies and gentlemen, to my own team of School of Public Health. There are 40 postgraduates, MPH students who have been tirelessly working day and night to make this event happen for the past 4-5 months. And again, a round of applause to all those young chaps, actually for them, who had made this happen. We know that the small, minute details of organizing a conference, different extramural project staffs under Dr. Kuldeep Singh, and under me, those extramural project staff are also a part of team. Some of the faculty, all faculty members, I would like to extend my heartfelt thanks to all the faculty members of AIMS Jodhpur, but a special mention of few of them, Dr. Dharamveer Yadav, who has been looking after the catering, Dr. Dushyant Agarwal, Vidhi Jain, Sojit Tomo, Ruchi Garg, Rimpaljeet, Minakshi, and Shrikant Srinivasan for their unwavering support to us. I think last but I say, this conference would not have been possible if I do not mention the names of two very strong pillars I have with me, my own dear colleagues, Manoj Gupta, who is additional professor in my own department, and Akhil, who is again my dear colleague, who have been standing by me for past 6-7 months in every discussion. Sincere thank to all the organizing team, which is led by my own senior, Professor Kuldeep Singh sir, and his team. I'm not naming my own staff because it's a huge staff of 40, 50, 60 people under me, but on behalf of on behalf of Kuldeep Singh sir, on my personal behalf, I would like to extend my heartfelt thanks. I convey my heartfelt thanks to the newly awarded NAMS Fellows, Associate Fellows, National International Medical Professionals who made this conference a success. Experts like those who have been sitting here, like the director of IIT Kanpur, I can see those who has been here in the convocation concluding ceremony time. Now, last but not the least, on behalf of my entire team of faculty, students, and administration, and as the organizing secretary of this conference, I would like to extend heartfelt thanks to all of you for being the part of this valedictory event today. And as the organizing secretary of the event, if there were any flaws or if there was any inconvenience happened to you during your stay in the event, extending apologies for that too. So thanks again, ladies and gentlemen, for your presence. And I think with the permission of all of you who are here, we close this ceremony as the valedictory event. Thank you so much, ladies and gentlemen.
We can have a group photograph with all the participants.
Oh, yes.
Awardees.
We can
Awardees,
have,
they
yeah,
can come.
yes.
And then we can have with everybody.
A parting photograph. Yeah, let's come.
So thank you, everyone. Everyone is requested to join us for a photograph, followed by tea in the adjoining area outside the auditorium.